Hello, I'm Professor Dylan Ritchie, and this is Fundamentals of Nursing 1, Nursing 310A here at Aspen University. And this is going to be over Module 8, which focuses on safety and the fundamentals of nursing surrounding safety for both patients and the staff in the facility setting. So let's talk about some of our learning objectives. We're going to focus our efforts on listing the factors that affect safety in the home setting, and we're talking about the patient's home. Next, we're going to dive in and identify the factors that affect safety in the community. And then we'll summarize and recognize factors that affect safety in the healthcare facility as the inpatient setting. So while we're not going to articulate this exercise through completion, if you look at this photo and ask yourself, what do you see, and maybe some of the safety issues that you can pick up very quickly as an educated medical professional. While this may be something that we in the classroom we may take for granted, a home health nurse or home health unlicensed staff will go in and see, maybe obviously not all of these as an exaggeration, but a good number of these particular depictions you see here out in real people's homes. So we're going to look at safety at the home and risks. You have individual factors, actually the patient themselves. What is their age and what is their development status? Are they able to function highly safely in a home setting? And what is the status of potential normal body functions or potential limitations there? Then you actually have to take in the house itself. What is the physical residence like? When was the home built? When was the age? This particular home, look, there's a lot of chipping paint. There's a lot of deferred maintenance. Is there any issues with the property that could lead to, think really young patients, lead-based paint? Poisoning in the home? Are things secured? Or is the home in such poor status that it has issues with carbon monoxide or things like that from a furnace or a water heater? A lot of things that we take for granted, and definitely our patients do too. And what you see for electrical hazards, if there's any suspicions there, do not hesitate to make a referral for a specialist, or obviously put in a warm handoff for a licensed electrician if it's truly a safety concern. Electricity is not something that you want to defer. When we're talking out in the community and the home population, home health naturally gravitates a lot towards, or a large portion of the population is aging and or already geriatric. So we have a lot of focused and individualized efforts in United States medicine for senior safety specifically. When we are looking at the home, there's a really well-made questionnaire that's been put together, and it makes you ask questions. What disabilities does the individual have? Are those identified disabilities, are they temporary? Maybe it's a home health referral because someone had major surgery. So we're only taking care of that individual for a short period of time due to acute need because they had surgical intervention, versus the disability or the home health need permanent? Is it just now starting and it's going to be progressive? Think while traumatizing, a good example is like ALS or something progressive, of that manner. uh, Steps to take. So when we're in the home, we're going to assess the individual's ability to function in their home. Again, the individual, how are they functioning in the home, assuming the home is fine and adapted for their needs? Can they function in that environment? We want to note activities and difficulties they have performing normal ADLs or activities of daily living. We want to notify the team and the owner of any obstacles that prevent the individual from performing the activity, and then we have to look at potential modifications either in the patient's behavior or modification in the home, physically or structurally. If the individual is having difficulty, it probes you to think of, okay, what are they having difficulty with and where do we need these modifications? Things, again, that we probably take for granted, like getting in and out of the home. How about using the stairs if it's a multi-level home? Can they actually get from one room to another? How about, okay, what do you do in the home setting as a normal residing citizen, right? You're going to cook, clean, bathe, toilet. So can they use the kitchen? Or does the kitchen need modification so that they can prep food, do dishes, things of that nature? Maybe where is their washer and dryer hookup? Does that need modified so that they can do laundry? How about bathing and showering? using the commode. Those are all things that we need to take into consideration when we talk about our senior population. So when we modify the environment safety, let's talk about outside the home, some of those regulatory bodies. Now you need to understand this at a high level. No one's expecting you to memorize all of OSHA's occupational safety guidelines, but as an educated professional, you should have a sound understanding of where to find that information if ever probed or needed to give to someone else. So where's your manual? Where's your online link? It's different from facility to facility. Again, you should be able to identify where it's at and reference it if needed. No one's expecting you to be an OSHA professional unless you go into that specialty. How about community safety? Again, CDC, high level overview, regulatory guiding bodies. You should be able to reference them and speak to them at a high level once you've been able to identify the resources needed. And obviously your CDC is a great one, the Centers for Disease Control and Prevention. So let's switch thoughts a little bit and look at healthcare settings governing agencies. So the Joint Commission. The Joint Commission is a United States-based nonprofit organization that accredits more than 22,000 United States healthcare organizations and programs. The international branch accredits medical services from around the world. A majority of United States governments recognize the Joint Commission accreditation as a condition of licensure for the receipt or being able to receive Medicaid and Medicare reimbursements. So Joint Commission sets out a lot of guidelines. The National Patient Safety Goals, which is abbreviated NPSG, this was established in 2002 to help accredited organizations address specific areas of concern in regards to patient safety. The first set of NPSGs went live January 1st of 2003, so not too long after its inception. The Joint Commission determines the highest priority patient safety issues, including NPSGs, from input from practitioners, provider organizations, purchasers, consumer groups, and other variable stakeholders. So another group to note would be the Robert Wood Johnson Foundation. It is an American philanthropic organization, and it's one of the largest that's focused solely on health. It's based out of Princeton, New Jersey, and the foundation focuses on access to healthcare, public health, health equity, leadership and training, and changing systems to address barriers to healthcare. The Quality and Safety Education for Nurses, which is QSEN, that project addresses the challenge of preparing future nurses with the knowledge, skills, and attitudes, they call them KSAs, necessary to continuously improve the quality and safety of the healthcare systems within which they work. So now let's focus on safety in healthcare agencies. Popular topic of conversation that you'll never get away from as a nurse will be falls. How can we prevent falls? How can we identify issues with falls that have occurred and prevent them in the future or change either the systems, the provider teams, the policies, procedures, you name it. If it can be identified as something that can be manipulated, facilities are going to try and do anything they can to prevent and stop falls. Especially in the geriatric population, depending on what happens with the falls, there's also issues related to reimbursement. So facilities, healthcare agencies are very much so from a PR standpoint as well as a financial standpoint. They're very motivated across the board to prevent falls. Restraints are always going to be a controversial. Simply put, any nurse, any medical provider, you're going to be guaranteed across the board, regardless of your facility's policy. You're going to have to exhaust all options before you ever put a restraint on a patient. Now, there's obviously different reasons and rationale why a restraint may be needed in the first place. Is it for a patient that's simply partially sedated and confused and trying to remove maybe a mechanically ventilation device? Or is it someone that's not alert and oriented? Again, depending on situations, you're going to have to really show that you exhausted all options before a restraint use will be performed. And then there's safety and constant monitoring once implemented if a restraint is used that the provider team needs to continuously assess. Medication administration areas are also a very hot topic in healthcare. Think things like BCMA, barcode medication administration, and other implementations to make administering medications safer. Do we have the right patient, the right medication, the right route, the right time, the right dose? All of your patient safety rights related to medication. Much like falls, there's constantly continuous improvement to see how we can leverage our knowledge, our lessons, and technology to make healthcare safer. Radiation and potential exposure areas, those are obviously specialty areas. Based on your facility's policy, you need to be knowledgeable on what PPE, what protective equipment you need to be using when radiation or in areas of radiation use, what you need to do to keep you not only your patient, but obviously yourself, because you're looking at exposure and more potentially regular exposure as a healthcare provider versus a patient that's getting an image at an irregular interval. Drug-resistant microorganisms, uh, obviously hospital-acquired infections, especially when they become drug-resistant microorganisms like MRSA and other variations there. There's a lot that we need to do to prevent and make sure we're using techniques to prevent people coming into the hospital and getting sicker because they acquired something facility acquired. And lastly, procedural errors, a very high topic overview bullet point. Depending on the intervention, we need to make sure we are doing our part as a nurse and checking all the boxes for the actions and responsibilities that we need to be accountable for when providing patient care and hands-on patient care. Let's talk about our fall assessment tools. Again, you will never get away from falls as a healthcare provider for the rest of your practice. So, for a little definition, in case you weren't aware, for the Morse fall scale, your facility is probably going to use this regardless of where you practice at. The Morse fall scale, the MFS scale abbreviated, is rapid, simple method of assessing a patient's likelihood for fall. A large majority of nurses rate the scale as quick and easy to use, and it is a very quick assessment that's going to cue you in to some simple interventions based on what the patient can and can't do. And on average, it'll take you only a handful of minutes to rate the patient. The scale consists of 6 items reflecting risk factors of falling, such as the history of falling, any potential secondary diagnosis, use of ambulatory aids. Is there any IVs or any type of medical equipment that has tubing? The type of gait or walking that the patient currently has paired with mental status. It has been shown to predict validity and reliability for falls and fall interventions. And the Morse Fall Scale is widely used in acute care settings, both in the hospital acute setting, thinking medicine, short term, and our long term health care settings. You're going to see this probably even built in to your facility's documentation as a quick click and fill scale electronically. The Stopping Elderly Accidents, Deaths, and Injuries Toolkit is a suite of materials that was created by the CDC, who we talked about a little earlier. They have a group, the National Center for Injury Prevention and Control. It is a provider resource adapted from American and British geriatrics that help assess and stop issues in the senior population for falls and injury. So let's talk about our nursing diagnoses and our goals. So we have the opportunity to identify risk for injury. So the patient will experience no injuries while hospitalized would be a good goal for short term while in the acute setting. For risk for fall, an example would be the patient will not fall when ambulating during the hospitalization. And lastly, risk for poisoning. A patient will not be exposed to household chemicals when discharged home. Depending again what's going on and what the risk for poisoning is, may guide this one. Our safety nursing interventions. So patient education is going to be first. We can educate, again, depending on what's going on. Wear shoes or non-skid slippers every time you get out of bed if the patient has a history of falls due to slipping via bad flooring or potentially footwear. How about you can call your nurse if you feel dizzy, weak, or lightheaded, and don't get up yourself. Some patient education there if in an inpatient setting. How about our safety promotion? We talk about the fire safety, the race and pass. The race pass is this fire safety acronym and protocol for rescue, alarm, contain, and extinguish when you first encounter a fire, and pull, aim, squeeze, and sweep for pass when using a fire extinguisher. This was developed for hospitals and nursing homes, and the RACE Pass is now used in workplaces worldwide and advocated by fire safety professionals across the United States. And it truly is a collaborative effort when talking about anything related to safety. It really does take everyone on the IDT team, including the patient, to make any environment patient and provider safe, and it requires ongoing and constant communication. Other nursing interventions for hospital staff education, you might talk about fall prevention based on your facility and the equipment available on the specialty ward or clinic area where you're at. Again, restraints is going to require to follow your facilities policies and procedures, and making sure you've exhausted all opportunities to avoid the restraint. Once the restraint is in use, you're going to have constant and regular checks to make sure that the patient does not cause injury, whether that's from the restraint itself or trying to remove this restraint. Side rails is going to be up to your facility policy. They can be viewed as restraints, and you may or may not be able to use particular rails on the beds that you have at your facility. We're always going to focus on safe medication administration using barcode medication administration in most facilities, making sure that you have the patient rights properly conducted before you administer the medication to the patient. And lastly, the reduction of patient transmission. Obvious things like washing your hands and using hand sanitizer at the proper intervals will go a long way in making sure that we are not passing germs or making people sick by coming to get the health care that they need for other primary diagnoses. And just like any evaluation, safety is ongoing and evolving. Please communicate well and listen to your team members, including the patient, and good outcomes are sure to follow. This concludes safety here for N310A, Fundamentals 1 at Aspen University. Thank you.